In this presentation, the person who comes in has dyspnea, orthopnea, lower extremity edema, as well as displaced apical pulse. So when all of these are put together, it puts the diagnosis forward that is decompensated heart failure secondary to left ventricular dysfunction. And so in terms of heart failure, hyponatremia is an important indicator to look at because it tells you how bad the heart failure is. So if you have a patient with heart failure, um, there's different aspects of physiology that go behind it. So if a person has heart failure, then they have low cardiac output, plus decreased perfusion pressure at the baroreceptors and renal arterial or afferent arterioles. So then what that does is that activates the neurohumoral release of renin, norepinephrine, and the secretion of ADH. So what renin and norepinephrine are going to do together, because there is a low cardiac output and decreased perfusion pressure at the level of the baroreceptors, is that it's going to increase proximal convoluted tubule resorption of water and then sodium. So remember, that's water follows salt. So if you have salt coming in, then water is going to come with it. And that's what leads to this edematous picture that you see in heart failure. And then also you have ADH, which is going to bind to V2 receptors at the collecting duct. And then once they bind at the collecting duct, that's also going to result in water resorption. So these two processes together, one and then two, that uh, that leads to free water retention, and that's what leads to the dilutional hyponatremia that you see associated with heart failure, and that's why I can tell you how severe the heart failure is. Here are some other random tidbits about heart failure. So when you think about hyponatremia, oftentimes it's associated with water restriction or yeah, fluid restriction. But in this case, you want to be careful because the patient's already edematous, so you're just going to make them more edematous if you do fluid restriction. So remember that fluid restriction and then salt tablets that can be done in SIADH, but it shouldn't be done in a patient who's already edematous um, because they already have volume overload. So if you restrict the fluid, then what's going to happen is that they're going to just absorb their body's going to compensate by wanting to absorb more water. And so, in patients who are on digoxin, there's no real benefit in increasing the dose of the digoxin because the toxicity increases, but the benefit of increasing the digoxin doesn't change the outcome of the disease. So there's no use in at a certain point increasing the dose of digoxin. And then also, if you look at the distal, if there's low distal sodium and water delivery in CHS, so decreased potassium excretion leads to hyperkalemia. Furosemides enhances um, K excretion, and then combined with ACE inhibitors can improve um, cardiac output and electrolyte abnormalities. So it's good to give furosemide plus ACE inhibitors as a combination.